Now let's proceed to our next session, which is on small bowel. Our respected chairpersons are Dr. Sanjay Basu, Dr. M. Manisegaran, and Dr. Prakash Kurumboor. Thank you.
Yeah, welcome to the small bowel session. And we have three difficult clinical problems in this scenario. The first one is about difficult enterocutaneous fistula, tips and probably the management I haven't mentioned. So, Professor Subodh Varshney.
I am going to talk about difficult enterocutaneous fistulas. As you know, it is abnormal communication between intestinal tract and skin, and when it is a communication between the mucosa of the intestinal tract, then it is called enteroatmospheric fistula. So these can be simple or complex. So generally difficult ones are the complex ones which have multiple tract or they are associated with abscess, and they are generally high output, more than 500 mils a day, and their origin is generally near DJ, or it would be ileal, or they are generally the lateral fistulas. The mortality and morbidity is very high, and enteroatmospheric fistula rarely closes spontaneously. The mortality historical used to be 40%, nowadays 3 to 10%, morbidity is more than 50%. It needs multidisciplinary approach. So you need a surgeon, intensivist, radiologist, and a nutritionist. And the sepsis and malnutrition is the foremost cause of death, so we have to avoid these two. So these are the unfavorable ones which would predict for non-operative closures, as I said, either ileal, jejunal, or non-surgical etiology, or if they are because of inflammatory bowel disease, cancer, or radiation. Either they are malnourished or there is sepsis, or if there is a distal obstruction, or the length of the fistulae are small. The smaller the length of fistula, difficult it is to close because they are more nearer to becoming enteroatmospheric fistula. So the main issues is sepsis, fluid and electrolyte imbalance, malnutrition, skin excoriation, and psychological. So management is a snap. You stabilize them adequately with fluid and electrolyte. You control the sepsis very aggressively, and you do an adequate skin care. You have to look into the nutrition by TPN or partial parenteral nutrition or enteral. Later on you define the anatomy, and then you plan later on how to deal with the fistula. Now in resuscitation you have to really give a lot of fluids and electrolytes, sometimes up to 6 liters a day, and you should not forget the electrolytes, calcium, magnesium, and trace elements, because these patients do get hypokalemia, hypomagnesia, metabolic acidosis, and vitamin deficiency. We should be monitoring them with IVC or CVP monitoring so that they are adequately filled, and urine output should be more than 50 mils. Before the serum sodium goes down, the urinary sodium will start falling. So that is one which with this you can monitor before the hyponatremia will show up in the blood. You give broad spectrum empiric antibiotics, and after a couple of weeks you have to add antifungal. You always cover anaerobes and gram negative. Now you have to do ultrasound and CCT to look for undrained collection, and then you have to drain them either with an interventional radiologist, or you will have to do a surgical drainage. Now when you have to do a surgical drainage for a sepsis control, then you do it after adequate resuscitation and stabilization, and you do a generous lavage, and sometimes you have to take out a proximal stoma or take down the anastomosis and exteriorize them. If you are not able to close abdomen securely, or there is an increased intra-abdominal pressure, leave it as a laparostomy, and then you protect these exposed intestines by supratule or with jelly on the gauze, and you can also use vacuum suction controlled dressings. And then you start monitoring these patients with cultures, invasive line you change weekly, and then you have an eye on white cell count and procalcitonin, and you have to repeat ultrasound and CCT as and when required. Now for the skin care, you have to prevent excoriation. So the simplest and cheapest is aluminum paint, or you can use stoma adhesive paste, you can use proper stoma bags or vacuum assisted closure systems. Once the sepsis and resuscitation is done, then the nutritional support is very important. You have to give them 1 to 2 grams of protein per kg and 30 to 45 kilocalories per kg. The aim is to give as much as enterally as they can tolerate, because even if we are able to give 25% of requirement, it helps in reducing bacterial translocation and helps in adaptation of the bowel lining. So this is called partial parenteral nutrition. Even if 4 feet of functional bowel is there, you can give low residue diets. There are formula feeds now which are dipeptides. These are partially digested. Ensure dipeptide is a brand name. And you can add on medium chain fatty acid, which is easily available as coconut oil. In proximal fistulas, you can have a nasojejunal feeding or a feeding jejunostomy. And remember, the requirement of the vitamins, trace elements, copper, magnesium, zinc goes up by 2 times, and of vitamin C by 10 times. To look for, to monitor the efficacy of nutrition, whether you are giving adequate, you would monitor the prealbumin, ferritin and retinol binding proteins. If the albumin is less than 2.5, the mortality is up to 40%, while if it is more than 3.5, the mortality is practically nil. Fistulochlysis is refeeding the intestinal effluent in the distal tract. What you need is a 75 centimeter of the healthy distal bowel. And you can feed around 60 to 100 mils an hour. If you can do it with a drip system, best, otherwise do it bolus, but every half an hour. In upper GI fistula, you give proton pump inhibitors because you want to reduce the secretion and increase the pH. The aim is the effluent should be alkaline or neutral. Octreotide reduces the output by 50%. If it is associated with COX, then you have to add on anti-tubercular treatment. If you are not able to give anything orally, then give Oflox and amic acid at least. In inflammatory bowel disease fistulae, you will have to give injections of cyclosporin 4 mg per kg for a week, followed by orally 8 mg per kg, or you can give a biotherapy infliximab or adalimumab. Loperamide, Lomotil and codeine phosphate, they all reduce the output. Later on, you will like to delineate the anatomy. For this, you would need a, do you have a pointer? For this, you can do a CT scan just with the oral contrast, and you can see the oral contrast leaking like in the first image, or you can do a fistulogram. In the second image, you can see that it's going into the bowel, or at an endoscopy in the upper GI or at colonoscopy, where you can see the hole, inner hole of the fistulae. If the fistulous tract is narrow and long, then T2 weighted image of MRI is better than a CT scan. Now the timing for closure, you have to delay these surgery for these fistulae as safely delay as much as possible, because many will close spontaneously. Each case should be dealt on individual basis. If there is no sepsis, fistula output is reducing and patient is recovering, wait till there is no further improvement. Hand sewn is always better than stapled suture line in fistula surgery, and always stitch on macroscopically normal bowel wall. For these complex fistulas, you should wait as much as possible and never before 3 months, and you might have to wait for up to 2 years if you had done a laparostomy and it was an entero-atmospheric fistula. So timing is to be tailor-made for each patient, which depends on ongoing sepsis, etiology, nutritional status, type of fistula, or whether laparostomy was done or not. Fistula surgery is technically demanding, so there is no single operation for all. It is tedious, so should be taken up only by experienced team, and they should set aside sufficient time for this operation because it can take hours and hours. You should do a sharp dissection rather than blunt dissection, because most of the injuries are by traction or tearing rather than the sharp dissection. You should do a near complete meticulous adhesiolysis, because only then you would make sure that there is no distal obstruction. Fistulizing segments should be resected rather than oversewn or bypassed. You can wrap greater omentum, and if the abdominal wall closure will be under tension, then you might have to do a component separation. In addition to the loop nylon for closure, you can add on interrupted 1-number proline sutures in between, and sometimes you might have to use absorbable meshes. There are also non-surgical therapies, but these are for non-complex fistulas like fibrin sealant. It is for long, narrow, low output inflammatory bowel disease fistulae, and it only expedites and reduces the time by 50%. Sometimes multiple sessions are required and the closure rate is around 55%. Endoscopic clips should only be used for acute fistulas, not for chronic enterocutaneous fistulas. Fistula plug has failed in anorectal, but here it is being tried again, but still there is no consensus. Recently, 3D printed fistula stent of thermoplastic urethane is being tried. We will see the results in future. So I would conclude by saying that enterocutaneous fistula management should be individualized and should be multidisciplinary. Phase 1, you should be very aggressive in resuscitating and controlling the sepsis. Phase 2, you should have a masterly inactivity where you only monitor and maintain nutrition. And in the phase 3, you have to delineate the anatomy and do a reconstructive surgery as late as possible from 2 months to 2 years, depending on pathology, condition of patient and type of fistula. Thank you.
It's a wonderful lecture, Subodh. And this is a common problem because most of us face this. We admit some patient for elective surgery and finally it lands up in a post-operative fistula. So how do you manage them psychologically? Because the important thing is managing the patient as well as the relatives. Well, they are also going to come after us.
So normally what I do is, first of all, I always involve one more surgeon in the decision, because if I have done an anastomosis and it has leaked, my tendency would be not to reoperate early and try to pray and think that it might heal. So you have to be really aggressive. Surgeon has to be really aggressive in the beginning. And there, if it is your patient, you have done it, then you would try to be more conservative. Second, I tell to the patient that yes, we have stitched and not all stitches have been taken up by the body. It is, there are two issues. One is a technical issue, but if you are experienced, I am sure it's not the technical. Then it is the patient. It is every patient has a different healing power. Every pathology has a different healing power. If you have done a resection anastomosis, it is for a pathology. So I try to convince them that because of the pathology and the patients may be malnourished or not so good, so all sutures have not been taken up, it has leaked, so we will have to reoperate, take the stoma out and then sort it out at a later date. Saving the life is more important, and if you take out the stoma early, I have seen the expenses are very less. Otherwise, TPN, higher antibiotics and these things, the patient family, they get financially into trouble also.
Any questions?
So what's the difference between enterocutaneous and enteroatmospheric?
In enteroatmospheric, it will be the mucosa will be which will be communicating with the skin. Okay. Otherwise, there will be an intermediate tract, fistulous tract.
What is the difference in management?
They never close spontaneously. They are like a stoma. They are almost like a stoma.
Still we have to wait for around 1.5 to
Yes, then you wait for a longer time, not before 6 months and maybe up to 2 years, and then deal it.
Okay, thank you.
Well, you told that you have to wait for longer
The best part they have found that the longer the tract, more chances of it healing and much simpler it would be, the fistula.
Yes, I agree with that.
So when the mucosa is towards the skin, it's not only the mucosa, even the bowel would be very much underneath the skin. So in these patients, generally we used to see these patients with the inflammatory bowel disease, the Crohn's ones. Tubercular ones are not, does not generally I see as much as I saw Crohn's in UK. So the saying was, after 6 months, reperitoneization starts after 6 months, where the peritoneal cavity starts reforming or redefining itself. Because before that, if there is a lot of inflammation in the peritoneal cavity, it is all inflamed cavity. So reperitonization starts after 6 months, so we should give at least 1 year to them, so that when we go in, then there will be no inflammation and no infection inside. It will be all like a virgin thing we are operating primarily.
I would take it a slightly other way. Suppose the patient is having a discontinuous fistula with the skin, and he's having a long tract. He will take time, but it will heal. But if it is a mucosa on the surface of the skin, then it is sure that it is not going to heal.
But you will not find a healthy peritoneal cavity.
Yes. Now, once the patient is hemodynamically stable, he is having a synthetic function growing up, you find that his albumin is increasing, patient general condition is good, then I think waiting for a 2 year is a very long period.
No, 2 years is not a, I have said 2 months to 2 years.
Okay.
And individualize every patient.
Yeah,
so
that's what I think
sometimes
that is
if
more
you
important.
do a laparostomy and it was a multiple enteroatmospheric fistula, then you will find that you will automatically wait for longer and you will find that it helps. Because the peritoneal cavity has to be redefined, otherwise where you are going to do a closure of the abdomen.
Actually, there's a study on the tract size. If the tract is less than 2 centimeters from the surface, because it is very close to the bowel, it's unlikely to heal. So the longer tract, they might heal with conservative treatment.
Just a non-surgical point, and this is true for all sort of potentially iatrogenic problems, is to get involved a colleague who's not involved in the original procedure. I think many of the points Subodh already covered, just want to summarize them. One reason is you get a balanced approach because you tend to be very emotional about it. So initially you want to be very aggressive. Sometimes you want to be very conservative about it. So it's always better to get a colleague in to whom you can trust and who has your good interest at heart as well. The other reason is that involving them also makes the patient feel it's not a cover-up. So especially if there's a need for a second surgery, it's always a good idea, because they're always wondering, usne complicate kar diya, so there must be some issue, gauze chhod diya, canchi chhod di, those kind of things are covered up. It also gives you a lot more of a balance to it.
In a partially granulating enteroatmospheric fistula, any experience of doing a split skin graft there as a temporary measure, sir?
A
partially granulating enteroatmospheric fistula, which has been managed with a wound manager, etc.
It will never stop.
Putting a temporary SSG, will it encourage the granulation process?
No,
sir?
it will not. Mucosa continuity has to be only with mucosa. That's the intestinal tract. So when you put a skin, that won't work. Later on, when you do a reconstructive surgery, you will have to do a suture line where the mucosal continuity has to be there, and the lumen continuity. Glue, yes, glue we did in anorectal a lot, and it
For enterocutaneous fistula.
enterocutaneous fistula, if the glue reaches the mucosa, then it will never heal. Because see, the healing should close at the mucosa. So if there is a foreign body, all these glues, cyanoacrylic glues, if you are using, they remain there like a stone. They never gets absorbed. So you can only put the glue partially, so that from skin till the tract where the bowel wall starts, only till there. Only then it helps. That's why they say that it works in few cases. Because if it goes up to the mucosa, in the bowel wall, it will never heal.
In our experience, only the narrow lumen fistulas and long tract fistulas are the two groups. If you are certain this narrow opening, if it is more than a centimeter wide opening, none of the glues work.
Yeah,
if it is less than if you have a small opening which continuously have a enter content coming out, you can fill it with a glue. That works over there. And it should be long tract. If it is a small tract, the glue will get pushed out immediately as soon as you put it in.
Yeah, the slide I showed said 55% success rate in long, narrow IBD fistulas.
Thank you, Subodh.